I'm very excited to have with us Gosalia, founder of AnginaX, an AI cardiovascular prevention infrastructure. Naman, you've built an AI-enabled cardiovascular prevention infrastructure at population scale. For those of us who aren't well versed in this, what does that mean and what does AnginaX do?
First of all, it's absolutely wonderful to interact with you, Ms. Ghosh. AI in health is no longer a technology story anymore. A couple of years ago on AI, discussion was around accuracy rate, detection, prediction, but now the discussion has become more serious, which is governance, regulation, public trust, right? Policymakers are not asking question whether your AI model is going to work or not. They're asking, was it verified on the people who's actually receiving the care? Is it going to be deployed safely? Can we audit it? Can we stop it? Does it gonna worsen inequity? Any AI tools that are sold as substitute for these fundamentals are not going to scale, even though they give scientifically very impressive results, is not going to operationalize it unless they're clinically embedded within the workflow.
And that's what AnginaX does.
So AnginaX is India-born cardiovascular prevention infrastructure, strengthening primary healthcare settings and making sure everyone is by default into cardiovascular prevention program and ensuring that the risk has been reduced to low risk and maintain and monitor for the rest of their life. And that's how we're going to win. And it's continuous, it's routine, it's operationalized in workflow.
And that's all driven by AI on your infrastructure.
Correct.
Great. Thank you. Thank you very much indeed.
See, the world is not suffering because of lack of AI capability. We already know AI is giving tremendous results in science. Okay, it is the implementation, the inability to implement prevention at scale. That's what we are suffering from. To solve this problem, what we actually need is the entire clinical workflow where every single stakeholder is engaged: patient, physician, nurse practitioner, paramedical staff, executive, government, ministries, because they all will have data. How many patients have been brought down to low risk? What is happening? So prevention, when it's continuous, longitudinal, follow-up adherence, ensuring that patients are remaining into low risk, that's how we make them stay away from angina or stay away from the symptoms.
I just wanted to say, how do we contextualize it though? Because as Roxana was saying, we're all coming at it from a view of AI being really useful in the developing world, in the developed world. What about the developing world? How does it help? How does it push boundaries? And what should we be concerned about?
Yeah, there are two ways of looking at this. One is the performance AI, which is only performance-based, has probably lack of evidence. We don't know exactly whether it's tested on Caucasian population or entire world's population.
Exactly.
That's one thing, right? So that's one thing. The second is more of high-value, governed kind of evidence-backed, risk-based, operationally logical, which is reimbursement logic, procurement logic, governance. That kind of AI is going to be implemented, but it is taking longer time. Look, Dr. Roxana, Dr. John, Dr. Moritz, everyone here will agree with me that we understand pathobiology of atherosclerosis in great detail. Vascular inflammation, lipid metabolism, all the cardiometabolic risk factors. What we lack is operational. It's not a scientific gap. To solve this problem, we need AI that can strengthen this and help our population to remain into low risk. And that's exactly why it should be embedded into entire clinical workflow.
So my name is Babar Hassan. I'm a pediatric cardiologist from Pakistan. And exactly your point. I think if you look at the device companies and the inequities created because it never kept the bottom billion in mind, I see the same thing happening with AI. All this work in the high-income countries with less than 1% data from the developing world. And this is from the maternal and child health world, which is heavily funded by the Gates Foundation. And there's less than 1% data coming from there. That's my first question. How do we make sure we don't make that mistake that the device companies made? And the second question I have is from this paper that talks about how AI is being projected in the narrative around AI of screening and making something very simple. Health systems programmatic delivery of quality clinical caregiving is a complex, fraught, labor-intensive process anywhere, especially within and among post-colonial geographies and people. So how do we not make sure that we do not make a very complex care delivery like congenital heart disease down to an AI just screening and diagnosing and forgetting the whole care continuum? Thank you.
Okay, go on. Yes,
Yeah.
Go ahead.
So that was a good question. First of all, whenever we talk about data, retrospective data, any device company, medical device company, when they build something, they have to ensure that the data is specifically that population. So we have AnginaX has built data from India because it's for Indian population. And we want to make sure it's for entire South Asian population as well. Doesn't mean that we won't be able to cover the Caucasian population, but that's how the system changes. The second thing is who's accountable? Who regulates that? MRCT, FDA, OECD. CDs compliance from India. They take 1 year of long process, an evidence-based process. So it is a stringent process. So any company who's building such kind of device, medical device, they have to go through this regulation process. Now, obviously, it's not good for some of the innovators who actually are building solutions based on the data that's available from global population. But if you think about it, there is one ethical question I want to ask. If we have the ability to identify avoidable cardiovascular risk earlier, and if we fail to build systems that do so equitably, isn't that also ethical failure? Because it's not only harm of deploying AI models, also harm of leaving preventable heart disease undetected because systems were too passive. I think this is national state story. It's a state capacity story. It's not just a technology story. That's what I'm saying. When AI is in health, now that is becoming more serious. It's more of a policy compliant, politically compliant. Government has to be part of it. We have to go through regulation. We have to make sure it's also for public trust. So every single company who's building anything to AI, they have to make sure that it is aligned with government compliance as well.
Give them a round of applause. Thank you so much, speakers.